So next speaker is Dr. Jyoti Prakash. He will be speaking on basics of OCT. As you know, OCT is the mainstay in the treatment of retina, and the basics are very, very important, especially for the beginners. Over to Dr. Jyoti.
Thank you, ma'am, and thank you, KSOS, for the opportunity. I'll be talking about basics of OCT. The basic principle, if you look at from a postgraduate's point of view, this has been done to death. This photograph has been there around for almost like 20 years, and nobody understands what it means. But everybody mugs it just for the heck of it. Similarly, that was the time domain, this is the spectral domain. It is just a difference in the light which is used. Coming to the retinal anatomy and the macula, as you look at it, it is all the 10 layers. And if you go into the histomorphometric morphometric analysis of it, keeping the two slides side by side, you can see actually how well spectral domain OCT depicts the histopathological structure of the macula. Reporting an OCT scan is very important. Just writing the diagnosis doesn't make you a good clinician. You have to be very precise with the way you interpret and you depict the findings. It is always mentioned in the sense of reflectivity. It can be a hyperreflectivity or hyporeflectivity. It could be of the layer or the dots or the membrane structure which is seen. It can have cystic or cystoid spaces and shadowing. Going just from the basic theory part of it, going to the examples, vitreomacular surface abnormalities, first of all, would include one of the photographs I've taken up from the article, which shows the various stages of the epiretinal membrane. From top, you can see it's the stage 1 epiretinal membrane, in which the foveal contour is very normal, and the layers are retinal layers are all intact in the normal, almost normal architecture. Apart from the hyperreflective membrane which is seen on the top of the retinal surface, you don't see any other abnormality. In stage 2, you can see an inversion of the foveal depression along with the presence of the epiretinal membrane. In the third stage, you see that the foveal pit is almost absent and there is a presence of ectopic inner foveal layers. And stage 4 is when actually the severe level of metamorphopsia tends to develop along with the ERM epiretinal membrane. You can see the disrupted retinal layers and the other stages, features which are present in the previous stages. Focal vitreomacular traction. Now this is when the PVD is induced at the other places but is attached at the foveal center. That is when you can see an attachment of the vitreous to the top of the foveal depression, and it causes a cystic change in the inner layers of the retina. As it progresses, it becomes slightly more severe, and this is how the picture looks. Looking at vitreomacular adhesion, if it is not pulling it, it is just attached to it, and it is called vitreomacular adhesion. When it progressive, it causes the pseudocyst, and as it keeps on progressing, it leads to a full thickness macular hole with the vitreous being attached to the operculum. And in the full thickness macular hole, the operculum gets detached, and you get a full thickness macular hole in the underlying area. This has to be contrasted with an lamellar macular hole, which is usually seen in epiretinal membranes. And the difference between the two happens to be that if you look in the full thickness macular hole, there is a total absence of retinal layers in the center. Whereas in a lamellar macular hole, it is only the inner retinal layers which are involved. If you look beyond in the subfoveal in the lower part of your scan, you can see the intact external limiting membrane, the RPE, the interdigitation zone, and that entire complex is intact. So the visual acuity won't be as affected as you would see in a full thickness macular hole. Intraretinal and subretinal pathologies, the most common one being diabetic macular edema. If you look at it, the first thing which we see here is a gross edema of the retina. It is called spongiform macular edema, in addition to multiple hyporeflective areas which are seen within the retinal space along with hyperreflective dots, and a subretinal hyporeflective area which depicts the serous macular detachment. This is a case of central retinal vein occlusion, in which you can see the massive cystoid macular edema. Branch retinal vein occlusion having a similar picture along with a serous macular detachment. Here the contrasting picture is that the area which is not affected has a normal profile, whereas the area where the occlusion is there, you see an edematous retina. Drusen or Drusens, how is it called? These are actually excrescences which are seen in the RPE. It's actually drusen. Drus is the singular word, drusen is the plural. PCV. Now, PCV, as we all know, is the diagnostic modality of test happens to be ICG angiogram. But is it possible to diagnose PCV on a case on an OCT? So it has been shown in literature that peaked PED, a thumb-shaped PED, a notched PED, and the presence of a DLS are also known as the double layer sign, and SIRE, as was labeled by Bailey Freund, it's called a shallow irregular RPE elevation. These are features which would direct you towards the presence of a PCV underlying. This is a macular neovascularization. You can see intraretinal edema, subretinal edema. You can see subretinal hyperreflective material. The presence of backscattering from the fibrovascular PED. And if you notice very carefully, you can see a compacted choroidal layer rather than the pachychoroid, which is seen in cases of PCV. This is, I'm just taking a few more seconds. This is very recent addition to the vocabulary. It is called ORT, the outer retinal tubulation. This is generally seen in last stage of macular neovascularization, along with scarred scarred AMD. This is just to show the dramatic effect diabetic retinopathy has in the final stages. It's a tractional retinal detachment. To one side of your screen, you can see a serous detachment. A tractional detachment along with a drill in the central layers, that is a disorganization of inner layers along with a schitic change in the temporal part. A CSR, this is how it looks. Isolated serous PED and serous fluid pockets in VKH. Did we come back to it or did we see upside down? Look long enough into the OCT, you will actually fall in love with it. Thank you very much for your kind attention.
Thank you, Dr. Jyoti, for that